Good evening and welcome to another episode of Fresh Natural Live. I hope your Monday's gone well. It's raining here in Houston, Texas, in our local area. And of course, we can use the rain. I have my garden planted with watermelon and various other things. And so it's been a good day, even though some people may say a rainy day is not a good day. But the topic today is attention deficit disorder. And my friend and colleague, Dr. Celeste Palmer, will be leading a discussion. We're going to discuss the causes and potential cures. So if you can't sit still and you look fidgety, this may be an excellent topic for you. But attention deficit disorder is commonly diagnosed in kids, but I see a number of adult patients who are taking medicines for it. In fact, some patients come to see me because their physicians and some psychiatrists are wanting to prescribe medications for their ADD, and they need a cardiac clearance. And so we're going to learn all about this. I'm really anxious to learn about this topic. And so we're going to get into the nuts and bolts of what ADD and ADHD is. So get your pen and pencil, get comfortable, get your cup of tea or coffee, whatever your favorite beverage is, and let's get ready to learn some stuff tonight. Hello again, and we're back just before I came back on, and so you almost caught me fiddling with my microphone. But anyway, as I said, we're going to be talking about ADD and ADHD, potential causes and potential cures. And I'm really anxious to learn about this topic tonight. As I said, I sometimes see patients who are adults who come in with this diagnosis, and oftentimes their primary care physicians are wanting to prescribe these medications for them, and I'm having to give cardiac clearance for it. So this whole issue of attention deficit disorder not only affects kids, but affects adults. And of course, many of you in the audience are adults, and of course, many of you have children. So this topic is going to be very relevant to you. So, our part one, we're going to talk about definition and causes, but without further ado, I'm going to bring our panelists in. We have Dr. Floyd Atkins in the studio today. Hello, Dr. Atkins. How are you doing today?
Hello, I'm doing fine today. Can you hear me?
Yes, I can. Slightly muffled, but you're coming through pretty clearly. So we'll keep an eye on that soundtrack there. Good evening, Catherine Welch. How are you doing today? I like that bracelet you have on there. I guess it's got some elements, some health elements in there. Maybe you can tell us about that toward the end of the show.
Okay.
Well, anyway, without further ado, I'm going to bring in Dr. Palmer, who's our guest lecturer today. So, this whole issue of ADD, ADHD, it seems like every kid has it, and every other adult has it. So, and I don't know, it's one of those things, I hear a lot of people, and then you see shows of kids on these medications and the like. And so I'm really anxious to learn about this. And as I said with the audience, we're going to take this in three parts here. And so part one, I'm going to ask you to help us out with the definitions and causes. So, what is ADHD and what was it? Oops, back there. So what is ADHD?
Okay.
And, what caused it? What is this disorder? Kind of we'll start off with the basics.
Okay. So just, today I'm just going to examine ADHD. It is a large topic. There's a lot of information out there on ADHD. A lot of it has not been scientifically proven. A lot of it is based on what works for certain people. Of course, there are medications that are proven, but I'll try to stick to the science. I do have some opinions, and maybe I'll have a chance to get to that at the end, because I have mixed feelings about ADHD. I know a lot of people I see a lot of children with ADHD. A lot of parents will ask, should they start medicine or should they not start medicine? And it's not a direct yes or no answer to that question, because it kind of depends on the situation and the environment. And that's what, we're going to talk about some today too, or tonight. So let's look at attention deficit hyperactivity disorder. That's what we call ADHD, or some people call it ADD, which is just attention deficit disorder without the hyperactivity. It is the most common neurodevelopmental disorder in childhood. And it commonly, the characteristics that are involved are inattention, hyperactivity, and impulsivity. And that most of the time children are diagnosed in their childhood, and the diagnosis continues into adulthood. And as we know, a lot of adults have missed diagnosis and don't have a diagnosis, and that affects probably the prevalence numbers that we're seeing in adults at this stage. But when we talk about inattention, we're talking about wandering, difficulty with focus, not being organized, and the child or the person is not doing this on purpose. They're not trying to be defiant. They literally cannot, turn things down and slow things down and pay attention. Hyperactivity can present as fidgeting, talking a lot excessively. For adults, it may present as restlessness, not wanting to sit in one space for a long time. You have to get up, move, come back down, sit down. So these words, I'm giving definitions of these words because it can mean different things to different people. And impulsivity, meaning desiring immediate reward. You don't want to wait for your reward, your gratification. You're interrupting others. Decision making, you're making quick decisions. These are definitions of impulsivity. So looking at prevalence, over the last 20 years, the diagnosis of ADHD has increased significantly. We're up to 6.1 million in 2016, and now that is 5 years ago. That is 9.4% of children under the age of 17 with a diagnosis of ADHD. And then, as you can see here, it's broken down into our preschoolers, our preteens, and then our teenagers, with the teenagers being at 3.3 million. Adults prevalence is at 4.4%. And I'll talk about why that number looks so low. And then also we know that girls, their numbers come in a little bit lower than boys. Boys are at 14% compared to girls at 6.3%. Now it is not, this is because of, like, more than likely it's because of underdiagnosis. It has nothing to do with girls having a less chance of having the disorder. But most of the time girls present with inattention. So they're not being distracted. They're not distracting the classroom. They're not being as aggressive. They're not being as active. So it can be missed. And so a lot of times little girls are missed. It doesn't mean that they aren't still suffering with some of the symptoms, but they don't get a diagnosis and they don't get treatment, unfortunately.
I'm sorry. So help us a little perspective. So 9.4% as of 2016, has that like doubled in 10 years prior to that, or what
so let's look at
okay, good. All right.
to here. I'll skip that one. So this is from 1997 to 2016. So we were at 6% in 1997. And so now we're up to 9.4. This shows about 10% in 2016.
Okay. So that's all kids, boys and girls.
Yes, that's all boys and girls. And then they break it down by race. The race differential shows that African-American children have increased the fastest over this time period, going from 5% up to 12.8%. Just very significant. And I'll go back really quickly. This curve just want to show the age groups 3 to 5, 6 to 12, 13 to 18, and then over 19. So our adults, as you can see, the total peaks around 6 to 12 years old. And then by your adulthood, we're down to about 4.4%. Again, some of this can be a little bit subjective. And this is where I feel it gets a little bit gray, a little bit blurry, because in the 6 to 12, 13 to 18 time period, we're asking children to sit in the classroom all day and listen to somebody talk to them. If we were to ask adults 19 and up to sit in the classroom all day and ask them to listen to them, I think we would have higher diagnosis. It's just that in the classroom setting, it doesn't work very well. In the adult world, you can kind of tweak your profession to what works for you best. So you find that a lot of adults that have attention deficit, ADD or ADHD, are doing jobs where they're not sitting at a desk all day, or they're doing something where they're moving so that they don't kind of have to deal with the symptoms as prominently as the children would, because children are being forced to be in the classroom setting. I hear you, but
I was so I'll go ahead and put this out there. So in medical school, I tell this story quite often, but so in medical school, I had my first year of medical school, I had a roommate, Pediatrics from Nigeria. And of course, in his upbringing, they were trained in these Catholic schools. And of course, I was trained in US schools. And again, I don't know if that made a difference other than the fact that I hear those nuns would pop your knuckles if you move too much. And so I guess he was disciplined very early on. And we kind of moved about. We got spanked too, but I don't know, maybe not as hard as the nuns. But nevertheless, I remember, and I never paid attention to this until Peter pointed it out. So we were in a fraternity dorm room, and we were both studying. And so I would sit at, and I knew I did this, but I just never thought of it until he says, he pointed out, how significant it was. But I would sit at my desk and I would read for a while. And then I would then take my book and I'll lay on the bed and read for a while. Then after a few minutes or maybe, then I would lay on the floor with my feet on the bed and then read. And then I would kneel by the bed with my feet on the ground, kneeling by the bed, then I would read. Then I would lay on the floor and read. Mm-hmm. Then I would get back at the desk and read. And then I kind of went through this little circuitry throughout while studying. And Peter, he sat at his desk. And I wish I had a videotape. We should have had a camera in the room just to fast forward it. Because he sat at the desk. And the only thing that would move was just his finger turning the page. And so I'm up there just doing my little gymnastics. And then he his page. And then he would look over at me, maybe the third lap or fourth lap back at the desk. He says, his Nigerian accent, Pascal, what's wrong with you? You can't sit still. You can't sit still. And so I just realized that, I was just more active. Now, I'm a little bit that way now, but I notice like in the mornings when my trainer comes, I work out. If I have to sit at my desk, I'm more stable after I've worked out than if I sit at my desk and try to work before working out. And I noticed that I kind of remember that in medical school. But anyway, I just put that out there. I was going to wait till later, but just hearing you give these diagnoses, so okay, let me just put myself online there. but I don't know I know that doesn't meet all the characteristics, but just with that piece of evidence alone, maybe make me a 14-year-old with the same thing, or 12-year-old, 13. Would that give you a suspicion of ADHD, or how would you characterize that? Just that piece of information.
Right. And I'm going to talk about the actual definition, but that's why I said, ADHD.
But maybe you can get into it later. I don't know, but yeah.
No, but that's why I said it's one of those things that I have an opinion about, because it goes both ways. And what I mean by that is, it is something that we look at negatively in children, and in adults, we don't really think about it, or we kind of make jokes about it. But it works well in our adult life because we're multitaskers, and that's what we call it, multitasking, right? And it works well because you have a business over here, you have the kids over here, you have spouses over here, and you're balancing all these things at the same time, and you have to make it work, and it works well. So, that's why I said, I have mixed feelings on giving the diagnosis, although, some children, when we actually talk about the disorder itself and how they are suffering, there is a part that, does need to be treated, because a lot of people, adults too, they do have symptoms that create suffering in their life. And that's what we'll talk about. But yeah, based on what you're saying, you probably would meet the criteria.
So maybe I put all these activities in my life to treat my disorder of ADHD. I'm taking pills. So I said, okay, I'll just give myself a lot of stuff to do, so that way I'll have time to sit still. But anyway,
yes.
Go ahead. I want to say hello to Catherine, Flea Bite Girl. Hello, Deborah Payne. Hello, Shonda's Real Food and Drinks, and Nicole Caldwell. Thanks for your comments and questions. We'll get to them real soon. Go ahead.
Okay, so looking at causes, these causes are kind of thought of as contributors and not really direct causes, but they speak about brain anatomy and function, which I'll talk about, genetics, things happening in pregnancy, meaning mom is smoking cigarettes or alcohol, other environmental toxins that the baby's exposed to, young children being exposed to lead, low birth weights, brain injuries, and premature deliveries. So there are other things that we think of as causing ADHD that science has said does not directly cause ADHD, and that's the sugar intake, screen time, questionable parenting, social environmental factors, and immunizations. So many factors can make these symptoms worse. So those things I would say can make it worse, but they cannot be named as the single cause of attention deficit hyperactivity disorder.
Is that due to lack of evidence, or just the fact that the evidence has excluded these as causes?
No, lack of evidence.
Okay, got it.
It's not excluded.
Okay.
Yeah. So part two.
Okay. So basically, to round this session up, you would say ADHD is a real disorder. There are real biochemical problems that are there. And there's a real set of definitions. One question, and I guess we're going to get into the diagnostic part, but and maybe you'll get into this later, but when you look at signs and symptoms, there is a strict criteria that you follow, right? You don't just look at the kid and say you've got ADHD, right?
Right, exactly.
Okay, and you'll get into that in the next part, right?
Yes.
Okay, well, good. So we'll take a break here, and then we'll come back to part two. As we talk about ADHD. I hope you guys are getting a lot of information. So next we'll talk about signs and symptoms and diagnostic criteria as we come back. Y'all stay tuned. So welcome back. So as we said, we're going to get into part two of discussing ADHD. And Dr. Palmer is going to take us through common signs and symptoms of ADHD and how we diagnose it. So what are some of the criteria and some of the things? So imagine now who come up with the criteria? Is this
is DSM. This is the DSM-5.
Okay. So do the pediatricians have into this?
Psychiatry.
That's all psychiatry.
Yes.
So there's not a common board, because sometimes, we have common boards at cardiology and pulmonology. So it's all psychiatry. The pediatricians just pull from the psychiatric part, right? Or do you refer to a psychiatrist to make the diagnosis?
We can diagnose ourselves. Sometimes it is multi other modalities involved. The children may have oppositional defiance and other things going on. So we may need to include psychiatrists. If they're depressed, also we need to include psychiatrists because they're going to add an antidepressant. But we can diagnose and treat ourselves. Gotcha.
Okay, so take us through the criteria.
Okay, so the diagnostic criteria for actual ADHD, and these are guidelines that we follow. As we said, there are no labs that we can draw. There is no imaging studies. I think sometimes parents think that we can do labs or imaging studies to determine if their child has ADHD, but it doesn't work like that. We do an evaluation based on information given to us from the parents, from the teachers, from other caregivers, and we put all of that information together to make a diagnosis. So for inattention, we're looking for 6 or more symptoms in children under 16 and under, and children 17 and up, or adults 17 and up, it has to be 5 or more symptoms. They have to be present for 6 months at least, and it has to be inappropriate behaviors for their developmental level. So for example, if a 2-year-old is doing some of the things where they can't focus, they're not completing a task, then that's considered normal because they're 2. But if a 12-year-old is doing these things over a period of time, then it's considered abnormal. So that's what they mean by developmental levels. So the criteria, again, for 16 and under is 6 of these things. So the items here talk about carelessness with their homework or other tasks they're being asked to do, trouble holding their attention, can't listen for so long, fail to follow instructions, cannot organize their tasks, they avoid doing tasks that take them longer than they really want to take doing it, for example, their homework or other schoolwork, easily distracted and forgetting their daily activities.
So, I'll let you go through all the,
Go ahead.
I'll let you go through the criteria, and I'm gonna make some questions on this once you get through the.
Okay.
Okay.
And then we have the type that is hyperactive and impulsive. So same thing, 6 or more of the symptoms in children 16 and under, 5 or more in adults 17 and up. We're looking at, when we say hyperactivity and impulsive, fidgetiness, so tapping your feet, hands, squirming in your seat, leaving the seat, getting up and down. In adults, it may present, as I said, as restlessness before. In children, they're going to climb things. They're up on the table, down on the floor, moving around. Kind of also a motor feel. So they're driven by a motor. They're always on the go, active, talking excessively, blurting out answers, trouble waiting their turn in line, for example, and interrupting others. They want to be a part of the game. They want to be a part of the conversation, and they just kind of jump in. Now, for all of these criteria, there are 4 parts here that have to be true also. So all of them must have presented with some of these symptoms before the age of 12. And so for adults who, for example, may not have had a diagnosis, when you go in to get evaluated, they're going to ask you, how long has this been occurring? Do you remember when you were little? Did this happen? Did that happen? Did your mother have to do this? Or dad have to tell you that? So that's how they do a historical history for adults. Also, it needs to occur in 2 settings. So you can't be having these issues at school and then not having the same issues at home, or vice versa. So it needs to be 2 or more settings, because we know sometimes what happens is children will do fine at school, but then when they come home, it's a whole different story. Now that is different. That's behavioral. That is not ADHD. Then also, go ahead.
You mentioned, and how about confounding factors? What if kids are going through a divorce and they're out misbehaving because of that, or other stresses in their life, or loss of a family member?
That's not ADHD. Yeah, so that would not qualify. Clear evidence that is interfering with their quality of life, school, work, for adults, and it cannot be explained by some other mental disorder like anxiety, depression, personality disorder. And what you just referred to would probably be separation anxiety from parents divorcing. That's a situational circumstance. So that would mean it would not qualify. Underneath these categories, there are types. There are 3 types. There's combined presentation, which is the inattention and hyperactivity, impulsiveness together. Then there's predominantly inattentive, and then there's predominantly hyperactive and impulsive. And in clinic, I actually see more combined. And then I think probably in the adult, as you get into the adult years, you'll probably see more inattention than the combined. Because As you get older, it seems that people are able to turn down their hyperactivity a little bit better. And this also, keep in mind that it changes over time. So over the years, like I said, a young child is going to be very active and moving around. As they become teenagers, they kind of slow down. So a lot of times we are able to kind of modify their treatment plans based on their maturity levels, which is a good thing. Okay, and so just touching on adult ADHD and quality of life. A lot of adults have fewer symptoms as they get a little bit older. As I said, some of them are not even aware that they have it. And then some have major symptoms that interfere with their daily functioning. Now, there are pros and cons, and we kind of touched on that. The pros of ADHD: very high functioning, good energy, empathetic, spontaneous, very creative, like you said for yourself. It works well in a certain setting. And so that's the part that can be a little bit difficult to just say end it all. And actually, I had a patient he's a teenager. He was probably about 14. He didn't like taking the medicines because he said he wasn't funny when he took his medicines. So he recognized, like, it turned off he's the class, he entertains the class. I don't like to use the word class clown, but he recognized that when he takes the medicine, he's not funny. He's quiet. He sits back there. He gets his work done, but his personality is taken, and he didn't like that.
Wait, so with that example you gave us, what was the life-limiting aspects of that kid such that he had to take the medication? And what was the impediment of his life? Grades? It's
always grades. It's mostly grades, yeah. Most of the time, parents are wanting children to, so that's the double-edged sword that I was referring to also. So I know a lot of people don't want to put their children on medicine. I've had that conversation with a lot of parents. But what ends up happening, and that's a decision that they have to make, is if your child keeps going through school and let's say you don't want to do medication, but you're doing therapy, the therapy may be a little bit slower. And they're failing classes. And so then they get the self-esteem issue of, am I dumb? Is something wrong with me? My classmates are getting good grades. I'm not doing well, and I don't know how to do better. And so then, because children compare themselves to each other, and then you don't want them to disconnect and say, forget it, I don't care, I fail anyway, so I don't care. So, you want to be very careful and mindful of that. And I want parents to make their own decision, but making a decision based on how does it affect their self-esteem and how they view themselves if they're failing and they get held back, or whatever the consequences are of, struggling through school, and you are the one that's always getting the failing grades.
So if you put so you have a kid who meets the criteria and they're failing, and you put them on medications, do you have to show that what if the grades don't come up on the medication? Do you increase the dose? Do you try another medication? I mean, what's the approach there?
We increase the dose. Yeah, we increase the dose.
Is it possible to put them in drama class or?
No, I use him as an example, but some of the kids, their issues are, and they'll say, when they get a teenager, they can talk to me and tell me what's going on. They can't keep their mind in one space, and it's frustrating for them. So they'll start doing something, and then their mind wanders off in a whole different direction, and they forgot what the teacher was even talking about. So for some people, it is quite frustrating for them because they're trying to do better, but they're having difficulty doing better.
Well, I've got some questions regarding other things you can try, but I'm gonna wait to your third section, which is treatments and potential prevention and cure. So cue me when we get ready toward the end of this one. We can go to break.
Okay, and then we have the cons of ADHD, as I said: low self-esteem, other problems, poor work and school performance, challenges with relationships, finishing simple tasks, traffic accidents for adults because just being impatient. So there's a higher risk, higher mortality rate, also from accidents, increased criminal behavior for some people, and increased suicidal behavior because of the impulsivity. And also some of them have difficulty with keeping good employment because of being consistent on a job becomes difficult for them, and then they have financial problems.
I got one question real quick.
Uh-huh.
So with the adults, you think maybe they have a lower, it looks like a lower incidence because you say they found a way to kind of mask their ADD. So you think things like self-medicating when it comes to as an adult, they can do things, whether it's food or whether it's alcohol or drugs or whatever they do to self-medicate, or coffee or whatever they use to handle that. And that might be associated with some of these other behaviors that they have. Do you think self-medication is a factor in them masking their ADD symptoms?
Yes, that absolutely.
Okay.
Absolutely. And really, I think that when the for kids, they are technically also self-medicating in a way, because when you're saying self-medication, you're not saying it in a good way. You're saying with drugs and caffeine and things like that. Children are self-medicating also with jumping from the table to the bed to the floor, because that gives them a dopamine rush.
Yeah. So
it makes them feel good.
Yeah.
So it's a self-treatment. I mean, and the other thing, I mean, Dr. Atherton mentioned self-medicating, but you alluded to earlier that adults will cover a mask or self-treat by putting themselves in work situations that don't require them to sit still. So the kids are doing, like you say, a similar type thing. They're moving about. Right. It'll be interesting when we get to the treatment section as to, should we look at other ways other than drugs? But that we'll get to that. Get my own mention says something interesting. Everyone is not meant for brick and mortar education, constantly sitting. We look at the child and say, okay, you're abnormal because you don't fit into this. And I guess if you put everybody into like a little mold, a little cubicle, you got the little walls squinched, you can't move. I think everybody would get a little fidgety. Some people get claustrophobic, et cetera. And then the people that are claustrophobic say, you got a disease. You can't sit in the little mold and be still.
Yeah.
Now you can extrapolate from that and say, okay, sit at this desk for an hour and, flip these pages. And that could be someone's level of claustrophobia. I mean, somebody put somebody on an MRI scan and they'll start to fidgety because they're claustrophobic. Now we have a term, a diagnosis, a definition for that, but we call ADHD something else. But is it the form frusc of the same thing if somebody's put in a real tight space and they get fidgety because they just can't stand to be there? And I think Get My Own's comment, touches on that in the sense that everybody's not made to sit in that kind of environment.
Exactly. I mean, and that's why, I said I'm going to try to stick to the science, but I have some personal feelings about what's happening because I see so many children that are have a diagnosis of ADHD, and I see so many adults that also say they have a diagnosis. So in present day society, like I said, it works in the adult world a little bit better than in the children's world. So the question is it time for us to change our whole school system, which is a whole political question, I know, because everything else in the world of a child moves fast, right? They're on the screens, they're on these computers, they're on these laptops. All of that stuff is moving fast. They're texting, they're watching videos, they're doing all this stuff at the same time. They wake up in the morning and they go, right? They wake up in the morning, they go to school, everything is on a go. And then we expect them to, and everything in our lives now compared to 20 years ago moves much faster. And actually children, when I watch these babies, these newborn babies are being born, they are able to lift their head on day one. That didn't happen when I first started in medicine. So I don't know what's happening. And that's why I said I didn't want to get too much into kind of my personal feelings, but everything is speeding up. And so it's kind of one of those things where it doesn't make sense for us to expect them to be slow in the classroom and sit there when everything else outside of the classroom is fast. But that's a whole discussion for another day.
Well, I'm going to interject here and maybe correct you a little bit, Dr. Palmer. I don't think it's your personal feelings. You're an expert. So you have an expert opinion, not a personal feeling. And again, we all do this. And that's why we have Fresh Natural Live. I mean, I read the literature. We all read the literature. But I mean, I've been reading literature for a long time. And I know when to see what's bogus and what's not bogus. And so, as experts, we're going to take the liberty of using our expertise and say, no, this is my opinion based on not only the literature, but also based on my clinical experience and based on the data I see, based on my intervention. So, I mean, we're going to get into this, and I think that's what our audience want from us. So you and I have had these discussions before. Yeah. So your personal opinion and my opinion is an expert opinion, and I look forward to hearing it in our next section. But you let me know when it's time to go to part.
Okay. And you know what? I actually just kind of tapped back over so I can see you all, and I see that Flea Biker Girls said the same.
Exactly. That's why I had it up there.
We're all saying the same thing.
Exactly. Yeah, I had that up on the screen while you were making that point. And I think these are very good points because I don't know. I'll make my commentary toward the end, regarding this so-called expert and the science and all of that stuff. But that gets into politics, and I'm not afraid to get into politics. But go ahead.
Okay. And then along with ADHD comes the comorbidities, as I mentioned briefly before: bipolar, ODD, depression, anxiety, learning disability, autism, sleep disorders, speech problems, learning disabilities. So these are also, sometimes we see these as a diagnosis along with ADHD that has to be addressed independently of the ADHD. Okay, and so let's look at the statements that it said about the brain functioning. So on the right here, you see the different parts of the brain and the different functionalities that those parts have. And then on the left, you see the different lobes of the brain. And what we know is that the frontal lobe is responsible for problem solving, memory, language, impulse control, social behavior, attention, ability to delay gratification, and time perception and attention. And so studies have shown that people who are diagnosed with ADHD, they have a delayed development of the frontal lobe, is what what's the literature says, or they have a smaller frontal lobe, is what the literature says.
Is that, do y'all do MRIs on these kids?
So there, when you look on, no, we don't. We don't do that in a real life setting. But when you look up information online on, ADHD and the studies that have been done over the years, they have done a couple of those, but it's not consistent. And, in science, when things are not consistent for every patient, it's not seen as a good way of diagnosing.
Gotcha. Because, you think they probably do, either PET scan analysis or MRI where they look at, brain function activity if you tell the kid to do some task.
Now, costs would be out over the rainbow if we were doing PET scans on everybody.
No, I understand.
Okay, and so then also looking closer at the synapses. So these are two neurons that release neurotransmitter from one neuron to the other to send a signal to the other side. And so basically what they have found is that there is a decrease in the release of the neurotransmitters, or either the other side is not catching the neurotransmitter, or the neurotransmitter that comes out is going back up into the transmitter that sent it out. So basically the connection between the synapse is not working like it should. And this is what they're finding in patients with ADHD. So for example, dopamine is the one that I mentioned before, is a neurotransmitter used for reward and motivation, helps us to complete our tasks, helps us to feel good about things, alert, excitement. So basically, if dopamine does not get to that other side, then your feeling of feeling balanced and feeling alert and excited, you don't get that. And so that's what we're seeing, is that a lot of people are not getting, with ADHD, don't have the signal transmission from one neuron to the next. So next is
treatment options. Yeah. One last thing on the last point you made. You said that the kids are treating themselves by moving around and giving themselves dopamine. And so it seems like you're alluding to the likelihood that increased activity and fidgeting, excuse me, increases the dopamine transmission. Is that
that's true. So, I didn't get all into it in the presentation, but there's like a tonic and a phasic type of dopamine, and the tonic dopamine is like the low level, the stable dopamine that is released from all of us, and then the phasic is the dopamine that gives us a feeling of something good just happened. And so, of course, when we eat certain things, so sugar is going to give us that dopamine rush, but also activity gives us that dopamine rush. So for adults, you go running, you feel better. The serotonin, the other neurotransmitters are released too, not just dopamine. I just use that one as an example.
Overall endorphins.
Right, are released. So for kids, they're not going jogging, but what they'll do is jump off of the table to the floor to the sofa, the same thing for them. They'll jump on a trampoline. These are the things that make them feel better because it helps those neurotransmitters to get from one neuron to the next. So that they get the sense of reward and motivation, and they feel good, and life is good. It feels good to them.
So what if I'm drinking a lot of sugary Kool-Aid and drinking a lot of, eating a lot of sweet cakes and honey buns and all that, and so I'm giving myself dopamine rushes with all the sugar, and then at a time when I have to sit down in class and I'm not able to eat my donuts and drink my Kool-Aid, my sugar levels drop and my dopamine rush drops. But if I'm giving myself these rushes of dopamine, my dopamine receptors, they desensitize, I imagine. And so if you got excess dopamine stimulation, you get decreased dopamine receptor density, so that you require more dopamine all the time. And so I'd imagine if kids are on sugary drinks all the time, it's a matter of too much dopamine being rushed from the sugar. But then when there are times when they can't have the sugar, when they have to sit still in church or class or wherever, then they need more dopamine because their receptor density is lower. Because if you have all this dopamine rushing, the body tends to decrease the number of receptors for if you got too much of a transmitter. And so and I imagine again, if you take kids on sugar, right, it'd be nice to have a way of looking at dopamine receptor concentration in the setting of high sugars, because the flip. It's not so much a matter of not enough dopamine, but not enough dopamine receptors because of too much dopamine from too much sugar and too much other stuff that may be triggering excess dopamine at certain times.
But then you desensitize the receptors.
That's what I'm saying. Okay. When you desensitize the receptors, then when you're at a time where you're not having all the sugars, then it's not a matter of not enough dopamine, but not enough dopamine receptors, which is the same thing.
Which is the same. Yeah, that's what this is saying here. Then the one side doesn't accept it. So now you kind of burned out the receptors.
So interesting. Well, that kind of leads us into part 3, which is going to be how we address that. And that's why I kind of wanted to kind of think through that process for myself. So anyway, we're going to get into the treatment, and we've outlined the cause, the problem, the symptoms, and all of that stuff. So as we take a quick break here, we're going to go into the treatment and potential cures, and Dr. Palmer is going to give us her professional opinion in terms of what we should do about this very common disorder. So y'all stay tuned. Okay, we're going to get into part 3, and we're going to talk about prevention, treatments, and potential cures. And before we get into the nuts and bolts, for those of you who are getting something out of this, and I hope that's a lot of you, please hit the like button. Also, if you haven't subscribed, subscribe to the channel, and also hit the notification bell. And of course, share this with any friends or loved one. This is valuable information, especially this part 3, because we're going to get into how you prevent, treat, and potentially cure ADHD. And Dr. Palmer is going to give us her professional opinion on this common and very important disease state. So anyway, so treatment options. I guess we're going to go to the basic stuff in terms of what the common treatments are, and then we kind of get into.
We'll start with kind of common, because it is a multi. I think it's only fair to take an interdisciplinary, multi situational approach, because it's not a simple diagnosis. It's not simple to treat. It's not simple to handle. And I saw a comment from Nicole Caldwell. She
is that the one?
Have a lot of emotional pain, and they do. They have. It's a lot that happens in homes that you would probably be surprised to learn about, and children absorb a lot of that. And this is sometimes how it presents itself. And sometimes it's not that. Okay, so it could be one way, or it could be not that. It could be everything at home is great, and they still have these symptoms. So it goes in so many different directions. This is a big topic to kind of grasp and understand.
And Get My Own has an interesting conversation. I think, and what I'd like to do, I'm just going to throw this up there now, but I want to come back to this comment toward the end, because when we get into a little bit of open discussion, we're going to talk about treatment, but I think part of treatment is going to be perspective. And I just throw it up there and just remind me to get back to that comment.
Okay.
So go ahead.
Okay.
We deal with this.
So when we talk about treatment, we talk to, of course, the healthcare providers, parents, teachers, coaches, other family members, and we get kind of everybody involved to see what symptoms this child is having and how can we help this child. Some parents do not want medications. So there are other treatment modalities, including behavioral therapies. And this is training for the children, for parents. This is behavioral intervention at school, organizational skill training, support groups, family therapy groups. So these are therapy sessions, and they do have that available for children, some through the school system, and some outside of the school system. So there are those choices. Now, those do take time, because you have to go over a period of time, and it's not something that's going to happen immediately. So the immediate result is where we look at medications. And so the FDA has approved down to 6 years old stimulants and non-stimulant medications. 70 to 80% of children on the stimulants have fewer effects, and it happens pretty fast with stimulants. So within like 1 day or 2 days, the parent usually comes back and say they can tell a difference immediately. Some of them, FDA has not approved the use of antidepressants, but sometimes, like I alluded to earlier, psychiatrists will add an antidepressant along with the stimulant for a combined effect. And we since it's not FDA approved to work like that, we let the psychiatrists do that. And then there are non-stimulants, which were approved back in 2003. They work, but they take a little bit longer. Sometimes they may take a month before you can see an effect, but they'll last in the system a little bit longer also. And so here are some of the common ones that we use. As you can see, there are short-acting medications that are from 4 to 6 hours, intermediate acting, which are 6 to 8 hours, and long-acting, which are like 10 to 12. And then the non-stimulants are up to 24 hours. So in most situations, and this would be for adults too, people take it in the morning, and that is all that they take. Sometimes, depending on if we're using a short-acting medicine or a longer-acting medicine, we may have to give a child a boost at lunchtime so that they can make it through the end of the day. Some children get a short-acting at the end of the day to help get them through homework, because sometimes parents are like, okay, they're good all day, but then when they come home, it's worn off and we can't get through homework. So we'll do something short-acting to help them get through homework. But you do not want to take these medicines too late in the evening, because then sleep becomes a major issue because they're stimulants. And so then you have difficulty being able to go to sleep.
Are these drugs mostly cleared through the liver?
I am not 100% sure of that.
Okay, I'll research that. Dr. Floyd Atkins, can you Google that for us real quick?
Sure, I
I
will.
think they are. Adderall, just look at Adderall and Dexedrine real quick.
I'm looking
But
at
I think they are.
Okay.
Okay, and so as the healthcare provider and caregivers, it's our responsibility to assess risk versus benefit for these patients. We ask the parents and also ask the patient, we have specific appointments that are set aside just for ADHD, where we talk specifically about how is school going? How do you feel? Do you have any headaches? How's your appetite? We look at the growth curves, because things that do happen sometimes is they start to lose weight. We don't want them losing weight because of the medicine. We don't want them having increase in their blood pressure or headaches and stomach aches and these negative symptoms. So we go through those. And if those things are happening, sometimes we need to turn the medicines down, or sometimes we need to change the medicine altogether to a different class of medication. Less common side effects from the stimulants are growth delay. We also see that where children are height-wise, they have a slower growth rate, and personality changes, hallucination, and suicidal ideation is also listed. The good thing about the stimulants is that a lot of times we'll suggest that parents take the medicine off on the weekends or take it off for holidays. Take it off over the summer. So if they're not in a situation where they're being expected to sit all day, you don't need to use it, because though these medicines are so short acting, as soon as you stop it, it kind of comes out of the body. Some parents say great, and that's what they do, and they do this with their child, and they are able to deal with it. Some parents say, you know what, I still have to take them to daycare, or I still have to take them to church, or I still have to take them to grandma, and they can't deal with them there. Now, when I say daycare, I'm talking about the 6-year-olds who go to after school care, not babies in daycare, because we're not treating babies. But so some people do choose to take vacations off of it, and some people take it continuously, and that's up to how the parents want to do it. We can't do that with the non-stimulant medications, because it has to build up in the system before we actually see the benefit. So you can't come off and on the non-stimulants as you can do the other ones.
That brings this diagnosis into big question. And again, I don't want to undermine, people that are having, significant problems, and I don't want to gloss over it in that way. But in my thinking is, if somebody has a health condition that requires a medication, I mean, it seems like if your health condition takes a vacation, when you take a vacation, it's sort of like, it's almost like putting an overcoat on, right? So when it's cold, you put the overcoat on. When it's hot, you take it off. And okay, that's an overcoat. But when you take a medication off and on, and I know we have PRN drugs, and maybe this could be considered a PRN drug, but maybe in kids who can come off, maybe we need to think about, the setting. I mean, is there something wrong with the school setting? And maybe we can make changes in the school setting. I'm not trying to propose a short-term answer here, but I'm just sort of raising a thought and raising a question. If these kids are coming on and off the drugs just based on whether or not in school or on vacation, maybe we need to rethink the school school segments or school settings rather, which was alluded to earlier. But anyway.
And there are schools out there. I forgot the name of the school type. It starts with a W, but because I have a friend who has her child in school where they learn. They're young children though. They're 5, 4, where they learn in an outdoor setting, so they don't actually sit in the classroom. This is pre-COVID, of course. They sit outside and learn and things like that. So those are private schools. There are private school settings like that. That is not happening in the public school, as we know. And
I hear Montessori schools allow kids to learn at their own pace, and I hear that they do more hands-on learning as well. I mean, I'm not. Yeah,
there's another. I know Montessori. I'm familiar with that one, but there's another one that takes it. That's what I'm saying, to another level of we're going outside to touch the tree. We're going outside to to touch the grass and put our hands in the dirt. We're going to do these things. And we have an outdoor classroom. I just forgot what the name of that school type is. It's not the Montessori. It's another one.
Yeah. Well, I mean, the old fashioned, public schools used to do a little bit of that. They called it PE, but they don't.
Yes.
Recess.
Yeah.
After lunch, we have recess.
And again, we laugh at these things, but I mean, I don't know what the schools are doing now. Dr. Palmer, you probably have a better sense, but I hear kids are having less PE or once a week and all that. We went outside every day.
Yeah.
And when I was a little kid, we went out and ran and got dirt, and it was punishment. It was punishment, to stay in. I mean, if I remember, my penmanship used to be bad. It's still bad, but anyway, I used to have to stand and do my writing, my longhand writing. I'd miss maybe half of PE. I'd probably get half, not the full hour. But I mean, we play flag football, and we throw the ball up, and we tackle and knock each other out, and we come back in. We're ready to sit still.
I don't know what happened a few years ago. It seems like it was something political where they kind of took physical education out altogether. Do you remember that?
Yeah.
So they did. They took it out, and then they came back and said, well, if you play a sport, then that can count as your physical education, and so you can get credits for physical education in other ways. And when you're in this grade, you don't have to take it, and in this grade, you do take it. So they have kind of decreased the importance of physical movement. And this is probably a result of that.
And maybe a correlation. Gabby, I want to ask a question. I think it's about the long-acting non-stimulants. How long does it take to release from the body? Does the brain, is there a brain and cell alteration?
I did look up the Adderall. It's all of those, and most stimulants, and especially that one, is a urinary release. They measure urinary output to see, so it's urinary excretion kidneys.
Okay, well that's good because it's not so much hepatic stuff, and so if kids have normal kidney function, that's good.
But again, with the urinary, it's almost immediate. Once it goes through, like I said, it's out of the system pretty quickly, and they measure it right away. So it doesn't stay around too long once you stop it.
Gotcha. I had a patient referred to me. It's a number of years ago, and I was in a professional building then in my practice, and the primary care physician sort of walked the patient to my office. It was a young man, and he was on Adderall, and he handed me an EKG. It was a 12-lead EKG, and the guy was in ventricular tachycardia. And so, of course, he put him in the emergency room, and we terminated. But I ended up doing a ventricular tachycardia ablation. So he had an outflow tract tachycardia. His heart function was normal. It had a normal EF and all. And we call it monomorphic. So we're coming from one site. But he was on Adderall, and I knew the Adderall, triggered it. I mean, if he wasn't on the Adderall, he probably would have had, ventricular tachycardia. He probably had a predisposition to it. So I remember before, the procedure, I was getting him ready for the procedure that next day, and I was talking to him. He asked me, well, should I take my medication? I said, well, definitely take the Adderall, because I wanted to be able to induce the ventricular tachycardia during the procedure. That way I was able to map it and ablate it. And so, but I get patients now who are adults who the psychiatrist or primary care physician refer them for cardiac screening because they want to start them on a stimulant for ADHD. And so, this could be a problem with adults who are prescribed it, and they may have an underlying cardiac issue. So I'm just going to say to the audience, if you are of the age, well, heck, over 30 at least, I'd say over 25, if you have any risk factors, high blood pressure, high cholesterol, diabetes, or high blood sugar, prediabetes, et cetera, go ahead and get yourself screened, by a cardiologist if your doctor is recommending one of these drugs, because you may have an underlying cardiac disease, and these drugs may, potentially put you in an arrhythmia, either atrial fibrillation or ventricular tachycardia or something of the like. And so always get yourself screened and evaluated, and possibly even followed up after you started the medication. And I'm just going to put a warning to audience. We're going to go a little bit over time, but I think this is a very important topic because I want to touch on some other issues as Dr. Palmer continues to go through the treatment section.
Okay. All right. And so I'm just putting this in here because when you, like I said, when you look online, these things have been said there's no scientific evidence for some of these, the multivitamins, minerals, EEG, biofeedback, kinesiology, sugar consumption, herbs, vision training. These are things, these are alternatives that a lot of people are using. And the science says that there's not scientific evidence. Now, let me put this as a side, say this as a side note, that even though these by themselves may not treat ADHD, they do help with the symptoms. And I feel like that's a fair statement.
Well, let me interject here. So, and I was going to get to this question, but the statement you made helps that with this. So, unproven treatment help. So, let me ask you this. So, and I don't know this, but has anybody done a study where they get a group of ADHD kids and change their diet and show a decrease in symptoms?
Yeah. Yes.
So let me ask you this.
It's just that it's not consistent with everybody, and they can't really measure it. So it's. So yes, absolutely, they have done that.
But let me ask you this. So you get a group of kids with ADHD, you put them on Adderall, you see a decrease in symptoms. That's proof of treatment. So you get a group of kids with ADHD and you change your diet and decrease sugar and they decrease the symptom. That's not proof. What's the difference?
Because with the Adderall, if I give anybody Adderall, it's going to change. It's going to, it does the same thing probably with everybody. Versus with the diet, is so many factors that when you're saying eat better, what does that mean?
No. I understand what you're saying. So let me be more precise. If I get 100 kids with ADHD and I put them on the prescribed plant-based Montgomery diet,
nobody's ever done that. You need to do that.
Okay. Right. So in other words, nobody's done adequate diet studies.
Right.
Okay. So nobody's done that because I mean, and that's what we do in our studies. We define precise with the diet. We don't even call it a vegan diet. We call it a prescribed diet, how the food's prepared, what it is. Because I mean, again, I was seeing a young man, high school age, who, and now I didn't make the diagnosis of ADHD, and I'm not going to try to make that diagnosis, but he was having a lot of issues. He came to us with cardiac issues, but he was also having emotional issues. He was angry and couldn't sit still, some other things. I don't think he met all the criteria of ADHD. That's not the point. But the point is that when he got on a prescribed diet after 1 week, not only did chest pain go away, other issues, but his behavioral things all cleared up in just 1 week.
Yeah.
And so,
I mean, because you have a unique situation, I guess I'm putting in a plug for you. You have a unique program where you're actually giving people a controlled food to eat. Nobody's done that where they've controlled what a child eats or people eat over a period of time, because there's so many, when you tell somebody to eat better, that means many things to many different people. So to be able to control that is a unique situation.
Well, I tell you what, after the panel, we're going to have to talk and we're going to put together. So I can think you can show a change, not in 30 days, but probably 10 days. Yeah. Maybe 5 to 10 days, you can start to see a change. I just need to get your input in terms of how we do that and measure those things, because I think we need to at least, I don't want to get into too much of this stuff, but it's just unconscionable that, we have our kids and we put them on medication, number one, for something that may be a part of the spectrum of normal. And I want to get into that in a minute. And the other thing is that to the extent that it may impede their lifestyle, their grades, et cetera, is something that can probably be treated with exercise and proper nutrition. And we're throwing pills at them like crazy. And part of why I'm sensitive to that, one, I have 4 kids. 2, I was in scouting with my son, and I remember we went on a scouting trip, and it was my duty to oversee the medications. And I thought I was going out with a group of nursing home people instead of young scout kids. And these kids were all on medications. And so I don't know. So again, I'm very sensitive to this whole issue, not just ADHD and ADD, but just the whole issue of putting medication, on kids at such a young age. Okay, these things are unproven. Why don't we put money and time and investigate and look at how we can prove them. Somebody needs to do an exercise. Can we just do 20 jumping jacks before class? Do something.
I understand, but then you kind of get into parenting, and then that's super sensitive subjects, because these are things that the parents, at home, certain things your children shouldn't eat anyway, regardless of if it helps with ADHD or not. And that's a whole discussion.
Well, what I want to say
and let your child sit in front of the TV all day or be on the screens all day. That's a whole discussion about parenting. So it's not just, that's the tricky thing about ADHD. It's not just one piece. There's a whole lot of parts that play in, because even if you do get 40 kids to come and be a part of a program that you put together, it doesn't help if the parents, the rest of the family is not doing it, and they're just looking at this one child. The child is still sitting in front of the TV or on the iPad all day. So, I think everything has to work together.
Well, that's true. One thing I want to say about this is that they say it's unproven, but there are countries like the Scandinavian countries, they do have research and data on using artificial colors and artificial flavors and dyes as a way to show that it's related to hyperactivity disorders in kids. But I know that a lot of those studies are not included in a lot of the, I guess, the information we use here in the U.S. But I do, and it's very complicated, like you say. I know that. So, but it has to be a way to do something other than throwing drugs at them and say, well, if we can't manage all these other parameters, well, we just give them drugs.
Right.
So
Go ahead. I absolutely agree. I agree with everything that you all are saying, because I thought about all of those things. And sometimes I probably sympathize with the parents because they don't know what to do. Yeah. When they're coming in and the teacher is saying, look, you need to do something or you're going to fail your child. Yeah.
So well, I'll tell you what, here's one thing I'm going to say. Again, here's my expert opinion. So I'm just going to put it that way, however you want to call it. One, I would willing to bet you take the kids. All the other factors are important. Home environment, all these things are important. I'm not discounting these things, but there's some simple things we can do. One, you make every kid a green smoothie, add spirulina to it, or add a blue-green algae to it before class, and you give it to them. Mm-hmm. And you have them do 20 jumping jacks, a green smoothie with spirulina and 20 jumping jacks, and maybe 15 push-ups as a higher dose for the kids that need a little extra. I guarantee you they'd be able to sit down and be still.
Yeah, but
and that's a simple study that can be done.
Okay.
You can get half the class and whatever. I'm just I'm speaking in general. I'm not fussing at anybody, but I'm just.
But what happened when a couple of years ago, we tried to change school lunches to make it something more nutritious for the children? People complained.
Oh, I understand that.
Remember that?
No, I agree. I remember I actually sat before the guys that ran the nutrition in Houston Independent School District a number of years ago, and nobody complained. They just circled me from meeting to meeting, committee to committee until I was dizzy and nearly passed out. But the point is, we could do a study. I don't know. We maybe have to go to a private school or someplace. We'll have to talk about this. But But the point is that something as simple as a green smoothie, spirulina, and 20 jumping jacks. Then if you don't want to do something more elaborate, you can do, some other things and so on and so forth. But it's really crazy. And we all agree that it's a complex problem. But we're taking a complex problem in one simple thing: take this pill. You got a complex problem, take the pill. Now, does that pill fix the complex problem? No. Because the underlying biochemistry, if there's enough pathology that's driving this force that's causing the kid not to be able to sit still, then we're just giving a pill. We're masking the outward side effects, but whatever that's driving that is the problem anyway. So I don't know what's going to happen to the kids down the road.
Right. And that, like I said, that's a whole topic for another day. Now, I'm not.
I agree.
I'm not promoting. I don't promote, I'm not saying that medications are the best So I want to make that clear. I'm not saying that they are just the fastest. I'm presenting the science.
And and again, here's the thing. Here's the thing. I agree with the science, and maybe like if the kid needs to be settled down tomorrow, give them the medication. So I'm not. I mean, I prescribe medications. We all prescribe medication to a certain extent. So I'm not saying this is anti-medication. I mean, let me make that clear. But what I will say is that let the medication be a temporary injection, and then you try other things, and then try to wean the medications. Don't just say, take this, and I'll see you later, until you're 99 years old. I mean, if you make it that long.
Oh, and we're getting there. We're getting there.
Okay.
Now, Dan Little says something interesting, and it alludes to your point. Patients in the Netherlands and Belgium were enrolled via announcements in medical health centers and through media announcements, randomization, both phases, interviews done by random. This is probably the study you're talking about, Floyd. In the open label phase, first phase, children 48 years were diagnosed with ADHD and were randomly assigned to 5 weeks of restricted diet, Thereafter, the clinical responders, but then I don't see the rest of your comment here, so you need to type the rest. I don't know how to get to the rest of that, but anyway.
But there are studies in other countries that they do that quite often as a remedy. That's their first step other than medication. I can see medication has a benefit in maybe extreme cases where you have to do something immediately. But say you have to change that underlying parameter. But I know what Dr. Palmer is saying when it comes to making those changes. I've worked with kids with ADD just through the diet, through the nutrition, through using enzymes, using antioxidants, using minerals. And taking kids off of Kool-Aid and red drinks. And I've had parents come up to me and says, "You messing up my household. You saying my kids to tell them we can't have this, Dr. And they were really upset about it. So I kept saying, "I'm so sorry. I'm just trying to help." The kids are loving it and they're making a lifestyle change. But that I guess the family pressure of you have to change the adults too. If the adults don't change, the kids are not going to change. So it's that household dynamic is tremendous. And I Dr. Palmer for dealing with the parents and the kids.
And that's very sad that the parents have that attitude. And sometimes, and I've been in that situation. Sometimes I just give them a lecture. I mean, say, okay, that's fine. You need to, make some changes. Hello, Cindy Goodson. How are you doing? Good to see you live. But you have to make changes in your way of looking at things. And so I don't know. I think it's just something that we have to really, really think about because it really affects our kids. And I mean, I deal with adults that are on too many medications, and now you're starting kids off at a very young age, and they go from one problem to another. But I mean, anyway, I'm sorry, I digress.
I understand. It is somewhat frustrating, but we always talk about nutrition because that's what I'm interested in. So I definitely am going to talk about nutrition. So even though the studies say that there is no definitive ADHD diet, and nothing has been proven that removing certain things or adding certain things is going to cure or treat ADHD, we definitely know it can help eliminate some of the symptoms and reduce some symptoms. So in theory, if it's good for the brain, it should be good for lessening your ADHD symptoms. So in looking at an ADHD diet, which one of the viewers mentioned, we're looking at overall nutrition, a supplemental diet, and also elimination diets. Overall nutrition, we know that proteins or amino acids are necessary, I should say, essential for brain health, because that's where our neurotransmitters are formed, the dopamine, norepinephrine, and serotonins. We get those in certain foods, our beans, lentils, and nuts. Complex carbohydrates, not the simple carbohydrates, help to prevent blood glucose spiking and help us sleep better. So our fruits, vegetables, beans, lentils, and brown rice. There are other ones, but I'm sticking to the things that are plant-based for my lecture since I'm a plant-based physician. Also, we have foods that help minimize oxidative stress on the body, like omega-3s, and that's our flax seeds, chia seeds, walnuts, and edamame. And actually, the FDA approved an omega-3 compound, which is Virin, as an ADHD medication. And I have used that on some patients, Some patients say they can tell. What we do is we combine the stimulant with the virin and then wean the stimulant off over time. And some parents say it works, and some parents say it does not. It doesn't. They don't see the difference. But it is a medication that is approved. It's the medicinal food is what it's called in literature. But from these studies on protein, complex carbs, and omega-3s, the studies have shown a modest improvement in symptoms.
So the virin, is that all omega-3, or is it omega-3 mixed with some other stuff?
I think it's all omega-3.
Wow.
I think it has phosphatidylcholine and omega-3 combined.
Gotcha. Maybe like a phosphatidylcholine. And phosphatidylcholine is a natural fat in our cell wall. So that's stuff. Fascinating. So that's some good, interesting things. And so, has anybody analyzed the diets of kids? I mean, we're looking at treatment, and then we look at brain stuff. Has anybody done an analysis of, kids with ADHD diagnosis typically eat these kind of foods? Has anybody done that kind of analysis?
I'm sure it has. So that's why I said there's so much information out there, and and I'm just trying to hit on what kind of the bigger points to make the point that we're feeding our child potato chips and chicken nuggets and these types of things, then there's absolutely no way that they can be getting the minerals and vitamins and substances that the brain needs to function properly. So that's the point that I'm trying to make with these slides, is that also studies have shown that micronutrients, the iron, the magnesium, the zinc, B6, vitamin D, folate, fibers, and all of these things also help with regulation of the neurotransmitters. And so these things, I'm trying to speed up some, so I'll take all night, but these items are in our green leafy vegetables, our whole fruits, our nuts, our legumes, our seeds. And so when you're not eating these things, then there's no way that neurotransmitter can do what it's supposed to do to send the signal to the other side. So I know that people, we have a tendency to think of child food as chicken nuggets and French fries, but you're starving your child when you do that, and yourself, because we're talking to adults too. You're starving your body of the proper signals when you do that, and so you're creating a situation where you're going to exacerbate symptoms and make things worse.
You're being very kind, Dr. Palmer. I would say you're poisoning your kids.
Yes.
That's what you're eating chicken nuggets. You're poisoning them.
Yes.
I mean, it may be, kid. I used to have, folks, we talk about the school lunch, and people say, well, have the kids eat the hot dogs or whatever. They got to get something. I say, it's better to eat no food at all than to eat some of the stuff that they're serving at these schools. I mean, seriously. I mean, it's sometimes it may be worse. I mean, I don't want to seem very cruel, but some of this food is very horrible stuff. And so we need to think twice. But anyway, go on. I'll settle down. My ADHD is kicking in.
And then we have the elimination diet. So with elimination, we some of these just need to be eliminated totally, like simple carbs. Our sweeteners and sugars will give us the blood glucose spike and crash that we don't need. And even though, as I said here, they don't link sugar directly with ADHD, we know that sugar is linked to diabetes, obesity, tooth decay, and a whole bunch of other things. And when we talk about sugars and sweeteners, it's not just granulated white sugar. Some people say, oh, we don't use sugar. I'm not talking about granulated white sugar. I'm talking about pastas, white rice, breads, chips, sodas, soft drinks, French fries. All of this processed food are simple carbohydrates, which will cause the blood glucose to spike and crash quickly. Caffeine also, in very small doses, I probably shouldn't even put this in here, may benefit, but the side effect is going to outweigh the benefits. And caffeine is going to intensify the effect of your ADHD drug. So this is, I'm talking to adults, because hopefully we're not giving children a lot of caffeine anyway.
Stephen Fairlove has a question about night sweating. Does ADHD have something to do with night sweating? Is there a correlation with night sweating that you know of?
Are we talking about with kids or adults?
You know what? I don't know. I guess either. I mean, they didn't specify, but kids or adults. I guess you're getting adrenaline rushes, but night sweats could be associated with a lot of things. People
not directly with ADHD, I didn't see anything about that, but your diet and sugars are going to spark your night sweating.
Well, in adults is going to be directly, well, one of the most common symptoms associated with hormonal imbalance. Well, in kids, she said kids, so I don't know.
She said kids.
Yeah, kids.
Yeah, I haven't seen anything on that.
Interesting.
And elimination of allergens. So if you know that you have a sensitivity to something, removing that, because that can exacerbate symptoms. And then you've already kind of touched on the additives. So it was a 1975 study that was done by an allergist. He took salicylates out. Salicylates being used in medications, also in preservatives and foods. And he did a study on a group of children, and in about 30 to 50% of the children in the group that he studied had improvement of their ADHD symptoms from removal of these salicylates. But they looked at the study, and from that study, they start looking at food coloring. They kind of don't really follow his study directly, but from that, they start looking at food coloring, like Dr. Atkins was talking about. So reds and yellows have been named as a problem. Of course, we know MSG, aspartame, sodium benzoate, also additives in cookies, soft drinks, fruit punches, and these are also colors that they're adding in these items. And also vitamins for children have a lot of colorings and things in it that we need to read and be mindful of, and probably remove once we see what it actually is.
Yeah, we got into that a little bit. We talked about professional grade versus over the counter. And so that's another example of how this over the counter vitamins you can get even from some health stores may not be good for you, because again, these things are problematic because they have additives and may not have much of the vitamins that you're looking for. Right.
And so science actually did come back and say, okay, the Lancet, Pediatrics, and the Journal Pediatrics, which are, reputable journals, they did say that if your child is, if you remove these things, it is advised that if they have ADHD to remove these type of things from the diet. So they did come back and say, it probably would be better if they didn't have they're talking about artificial additives specifically, not everything on this list.
Yeah, and too bad they couldn't make the next connection that other foods could be problematic too. It's just, okay, we only saw these things and we can only see these things. And, we're so myopic, we can't think that, hey, maybe there are other foods, or the lack of foods, the presence of foods, that's just very irritating. But Pat Lathrop want to know about seizures. Is the ADHD, ADA connected to silent or absent seizures?
So she's referring to absent seizures. So sometimes ADHD, probably if you have inattention and you are daydreaming, it could be a misdiagnosis in the sense that you may think it's ADHD and you are and the child is daydreaming, versus they're having an absent seizure, which is two different things. They just might look similar.
So basically, the absent seizures or typical seizures are related to misdiagnosis more so than an association.
Right.
And then prenatal vitamins. This is an interesting question. Prenatal vitamins, could that be? These prenatal vitamins are often over the counter. I don't know how. I typically take people off prenatal vitamins and put them on something natural, but
I think that's a stacked question, because the lack of certain vitamins is going to set up a situation where you might, deal, because we just talked about magnesium, iron, folate, and all these things are needed for the brain development. So if you don't get those vitamins, you may be dealing with a situation later in life, or with the child's life, where they have ADHD. Now, the type of prenatal vitamin, who's sourcing it, what products are in it, that's what you want to find out and do research on before you start taking a prenatal vitamin.
And I want to kind of clear. You raise a good point. Yeah, the lack of those nutrients. Right. But a lack of a nutrient in the presence of a vitamin or of a supplement does not necessarily connect to the replenishment of that nutrient. I could take prenatal vitamin X, or somebody could take prenatal vitamin X And it can have all sorts of colorings and dyes and cereals in it, which you alluded to during the research, and it could be doing no good but harm.
Right.
And Dr. Atkins could speak to this because he talked about it before. A lot of these vitamins don't even have the adequate amounts of what it says it's supposed to have in it. What are your comments on that? So if you took a prenatal vitamin X, it's supposed to have all these nutrients. I mean, how do we know that it's not causing a problem as opposed to causing some benefit?
Well, one thing I want to say to that is the main thing with the prenatal vitamins that I find that the vitamins are synthetic vitamins. They're synthesized in a laboratory, and those have been shown not to be effectively work. It may be chemically in structure to the natural vitamin, but they don't have an effect. The minerals are so important. Vitamins, vitamins make the minerals work. You need both of them in context, but when you get a prenatal, you get a synthetic product and you get a mineral, which minerals are pretty much natural either way they come. So people are taking something and it's not really effective. So again, like Dr. Palmer said, it has to be a source. It has to be a plant-based. It has to be from an organic source. The vitamin needs to come that way if you're taking it, especially in the prenatal situation, because it's just not working. That's all. It's as simple as that. Synthetics do not have the same effect.
But I like this question about Stephen Fairweather because not only she is alluding to the lack of efficacy, but there's alluding to the potential harmful effects of prenatal vitamins. I don't want to say prenatal vitamins are not healthy. There should be optimal prenatal nutrition.
Yeah.
That way. But just to say, take a prenatal vitamin, and for the points you made, both of you made, they may not be healthy and they also may be harmful. They're chemically synthesized. They may have chemical dyes. Dr. Palmer mentioned earlier, children's vitamins. Well, prenatal vitamins may have the same stuff. So we may be causing harm potentially with these so-called vitamins, prenatal vitamins or otherwise.
Yeah.
I mean, I just like that question because it points to the flip side. We often think of vitamins and nutrients and say, well, it's either helpful or not helpful. But there's a third part to that. Can it be harmful?
Yeah.
Right.
Anyway.
Well, that's why too I was listing food sources. Even that's a large topic too. Food sources to be able to get some of these minerals and vitamins into the body.
Yep, that's important. Optimal food is going to be the foundation. And
so, really briefly, also other modalities, we kind of touched on these two: exercise, yoga, Tai Chi, good sleep hygiene, outdoor time, green time, mindfulness practices, calming music, talking about the different hertz that we have discussed before. Are also methods, modalities that by them in combination with the foods, in combination with some of the other things that we are working with, can help children to be able to have a better experience in the classroom, and also have a better interaction in their lives. So the future of ADHD, I threw the first one, further studies on nutrition, supplements, dietary modifications, and elimination eating, because there's so much information being done, so much to say that they kind of need more studies on and more to do. And we alluded to maybe, we'll do a study. Maybe we'll do a study. But there's a big need, and I don't think anybody has kind of stepped up and done that work in that area yet and really been committed to finding those answers. Then on the forefront also, they're doing gene therapies. So, this is in the laboratory. They're looking at certain genes that children with ADHD seem to have in common, and they're looking at things to target the genes. So we will see where that goes. And then they also are starting to use virtual reality. And this is kind of newer on the horizon. It is being used, especially during the pandemic. A lot of children have not been able to get to their behavioral therapists. And so there's a company that gives these virtual reality systems to these families, and they watch certain things on the screen, and the virtual reality glasses capture the eye movement, so it can kind of track and tell them if they are distractible, how they're doing, how they're progressing, and if they're doing any better. So that is what they're looking at now as far as the future of ADHD and how to kind of help these children, and also thinking about using these virtual reality systems in the classroom setting to help teachers to be able to help the children a little bit better.
Wow.
Yeah.
You know, this, and I want to throw this question in. Thanks, Dr. Palmer, about the get my own asked earlier in the conversation, and I put a pin in it. And it triggered some thoughts. And so, is it true that most entertainers and artists are ADD and bipolar? And so, not that I want to get into a full-blown discussion of psychiatric disorders, but what I'd say is this. I mean, there are a lot of conditions that we look at, particularly the condition that deals with behavior. And one thing we have to do is we have to look at things as part of a spectrum. And you alluded to it in your talk with the diagnosis of ADHD and ADD and ADHD, is that, you know, a big part of it is that it has to impact their lifestyle in terms of kids' effect on their grades, and adults' effect on their ability to, you know, perform normally, et cetera, et cetera. But this question alludes to these potential quote unquote disorders contributing to a greater performance. I mean, people's creativity. You alluded to it with the one example. The guy said, well, I'm not funny, you know, when I'm on my medication treatment of ADHD. And so part of the question I'd like to raise in interjection is that, one, yes, these quote unquote disorders can be related to abnormalities of biochemistry and physiology, or imbalances, I should say, in our biochemistry and physiology. But then the other way to look at these things is that, are they, to some extent, a part of a normal spectrum? You know, we look at somebody, and I'll use depression, not that we're getting into all diagnoses, but I've had people come in and they say, well, you know, my PCP started me on an antidepressant or whatever. And so, well, you know, why are you on the depressant? Well, you know, I was feeling down because, you know, my parents died and the kid died and I lost my job. And I said, well, wait a minute, you know, if you're not feeling depressed with that, I mean, then we need to, I mean, it's abnormal not to be depressed related to that. Now, I'm not saying you don't need medication or do need medication, but I mean, some of our behavioral imbalances are related to appropriate responses to environmental stimuli. So we got into this with the ADHD. You know, if you box up in a room, maybe being boxed up in a room is abnormal, not the kid is abnormal. And so you may, this question about entertainers, you know, maybe you have a predisposition to be more expressive and more creative. And so some of these things need to be looked at, as a slight imbalance of biochemistry and physiology. So we address that in a natural way. That's number one. Number two, the other way of looking at it is that these quote unquote abnormalities are a normal variation of normal. It's probably more normal to kind of want to get out and feel the grass and walk around and move about and not sit still. And so some of the things that we look at in our formal educational systems, where we say, okay, those of you who can sit still the longest and check the right box that we tell you to check, you're going to get the blue ribbons, and the rest of you guys are just going to get, you know, C's and D's, etc. But then when you go look at professional schools, I remember talking to the head of the MBA school at Rice years ago. I was contemplating taking one of their professional development courses. He said he had done studies at MBA schools around the country, and you take the top ranked student down to the bottom ranked student, and you turn that list upside down, and you can predict their success in real life. And he says he did it multiple schools over multiple years, and the findings were very consistent. Now, I use that example to simply say this. I mean, we're using a barometer, i.e. the formal educational process, as a measure of a disease state, when in fact, normal behavior or variations of normal behavior exists outside of that contrived, structured environment. And I think I have some problems with the fact that, success within that contrived, structured environment dictates disease states. It's sort of like saying, I was watching some YouTube videos on some old Muhammad Ali boxing match, and I was just thinking to myself, God, those guys are really tough, and it really takes a special person to be a boxer. Just imagine we all had to go and box and say, okay, if you can't stand in the ring, one ring with Muhammad Ali and Mike Tyson, there's something wrong with you. Well, a whole lot of people will be. The point is that we all have different talents and capabilities, and everybody has a different spectrum of normal. And we're calling people that don't fit into this box abnormal when some of them are creative, like the example you gave, and like what I think Getbaum alluded to. In fact, entertainers and artists. And we need the whole spectrum of people. So we need to figure out how we can look at the whole spectrum of human normality instead of trying to put everybody in a box. And if you don't fit in that box, you're abnormal. I'll end it there. Any comments or follow-up?
Oh, no, I think you did a great job.
I think again, it's just one of those things that maybe we hit a button and my ADHD went off tonight. So maybe I get Dr. Palmer to prescribe me some Adderall so I can go to sleep or something.
Some greens.
A green smoothie and 10
No, you do some mindfulness, breathe, meditate, quiet time.
No, this is a great discussion. Look, I really thanks for the wonderful discussion, Dr. Palmer. We did go over, and I apologize to those of you on live, but again, if you couldn't see the whole show, we're gonna have it recorded. We're also gonna break it up into different parts. But do send this off to friends and neighbors. Because I think a lot of the points that were made, by the panel, and also questions and comments made in the chat line were right on point, very excellent. So I want to thank everybody for your comments and questions. And again, also hit subscribe if you haven't. Hit the notification button. Give us a thumbs up if you got some information for this, and please share this. Lots of people need to see this or hear this information. I'll see you guys backstage while I close out. As always, I get a lot out of this show, and this is an important topic, not only because it affects kids, it also affects adults, but it really gets into the crux of how we make diagnoses and how arbitrary medical diagnosis can be. I'm not trying to pick on ADD and ADHD as a diagnosis and diagnostic criteria, but it's certainly a disease state that I have personally seen lots of kids get diagnosed with it without very much investigation as to, what other causes are and so on. And so we're so easy to write a prescription. And I think we need to do this. And as I speak to you, if you have a loved one or even you're a patient and you're given this diagnosis, just give some thought to it and give some thought to what impact, it's having on your life, and don't just settle for the first diagnosis, the first form of treatment. Maybe get other doctors to opine, because making a diagnosis isn't straightforward. Sometimes I have my patients get a second opinion on a diagnosis they have a question with, and so I ask you to do the same thing, especially for this important diagnosis. So again, sorry we went over, but a very important topic. We hope that you share this with loved ones or anyone who may benefit from it. And until next time, keep it fresh, natural, and live.